Welcome to the second half of Pertinent Positives. Thanks for joining me. Once again, I'm Dana Resop. I'm one of the emergency medicine attendings who also specializes in point-of-care ultrasound. And today we're going to be talking about gallbladders, kidneys, as well as some early trimester pregnancy, some ocular, and some central line ultrasound. Let's start with gallbladders. So here is a nice, beautiful gallbladder. The question on our point-of-care ultrasound for gallbladder is, are there stones? So as you're watching this ultrasound, here is the skin up here, abdominal wall. Here is liver, and then here's the gallbladder. As you're looking at this gallbladder, one thing to look for, are there stones? And if you don't see any stones, then the next thing to look for is there shadowing? So this gallbladder does have stones present. And if you didn't see it, don't worry. Most people don't see it on the first view because you haven't seen stones yet on most of your patients. So this is the gallbladder right here. And if you look right here, here's the top of a stone, and here's the top of another stone. Sometimes they're a little bit hard to see, so the other thing you can look for is shadowing. So here behind the gallbladder, we have some bright area of the liver called posterior acoustic enhancement. Okay, and then right here, all of a sudden it disappears. It's this very hard line on the edge of the gallstone, and you see nothing over here until we get over to here, and here we have what's called dirty shadowing. I'll start this playing again so you can see that. And that's when you get air in the intestine or someplace else that just kind of fuzzes out everything behind it. It's called dirty shadowing because it's kind of a combination of bright and dark. As we're scanning through here, you see how suddenly the tissue behind the gallbladder disappears all of a sudden when we get to these stones. Let's look at some more. This one's a little darker. Skin's here. Abdominal wall here, liver here. Are there stones? Once again, there are stones in this gallbladder, and once again, they're a little hard to see, and so you might actually pick up on the shadowing more than you pick up on the stones. So let's stop this here for a second, find a good spot where we can see everything really well. So here's the gallbladder wall, and here is bile within the gallbladder. This gallbladder is actually a round structure right here, but looks like it's cut in half because the top layer of stones is blocking all the ultrasound from coming back. So this is all acoustic shadowing behind it. This is a gallbladder that's full of lots and lots of gravel that's just settling down in this kind of half moon sort of a pattern in the inside of the gallbladder. One other finding that you may have noticed is that there's some strands of something inside this gallbladder which might indicate some infection and is concerning. Positive or negative? If you see stones in this gallbladder, you are correct. There's a couple other findings here as well. One of them is that this gallbladder wall is a little bit thick, and it's very subtle because the image is a little dark, but there's just a little bit of what's called pericholecystic fluid, or a little black rim of fluid around the edge of the gallbladder. In addition, this gallbladder is full of concentrated sludge, so it looks just like the liver. It's called hepatization, but it indicates that there's a blockage somewhere. Sludge isn't always pathologic, but when you're seeing this much in a patient who's having abdominal pain and has stones, the next thing I look at is the common bile duct. So this is the portal triad right here. This is the portal vein. This is the common bile duct, and the hepatic artery is kind of little and is actually just missed on this frame. The common bile duct should never be more than half of the size of the portal vein. So this common bile duct, just glancing at it without even measuring it, it's actually about 1 centimeter wide. This common bile duct is pathologic and indicates that this patient probably has a blockage. And in this case, since the patient also has gallstones, it's probably choledocholithiasis. Here's just a freeze frame of that gallbladder. Here are the stones up here in the fundus, and then here's that common bile duct, here's that portal vein. Sometimes it's a little bit challenging to differentiate the IVC from the portal vein, so look at that on the next page. Here's a picture of the liver right here. So if you're looking for the portal vein, the best way I can tell you to look for it is it's the biggest circle with bright white all around it that also has liver behind it. Okay, so there's a little piece of liver back here. The IVC also is a big circle with bright white around it, but it shouldn't have any liver. This is the IVC down here. This gallbladder isn't imaged completely, but really this clip was to look at the portal vein more so than it is to look at the gallbladder itself. Here's another picture of the portal triad. This one's a beautiful view of the IVC. Here's the IVC in sagittal view. And there's a little tiny circle behind it. This is the right renal artery coming over from the aorta and sneaking behind the IVC. Here's liver right here, and here's that portal vein right here. So biggest circle with bright white around it that's got a little bit of liver behind it as well. This is a little bit advanced, but a little fun fact is that the vessels always stay together. And so if you see a picture like this where you have the portal vein, this little circle right here, and then another circle or another tubular structure jumping over it, this is always going to be a vessel. So this is the hepatic artery. It always hangs out with the portal vein. And this is the common bile duct that's hopping over the top of it. It's pretty hard to see in normal patients like this one. But in patients who have biliary pathology and a dilated common bile duct, it becomes much easier to find. Here's another gallbladder. These can be really hard to find. Sometimes you have to find the portal vein and then look around the portal vein to find the gallbladder coming to it. This is a contracted gallbladder. So this is actually not an ill or sick gallbladder, although it does have a thick wall, but it has no stones. And it's really just that the patient has either had a meal recently or they've had some sort of medication or something else that's made their gallbladder contract. So they look like they have a thick wall, but there's actually nothing wrong with this gallbladder. Here's another picture of a portal triad moving onto the gallbladder. Positive or negative? I hope you said positive. There's a lot of stones in the fundus of this gallbladder. Here's the shadowing stones right up here. This is the fundus, and then here's the body. There's no stones in the body. But then when we get to the neck, the portal triad shows up quite distinctly because it is abnormal. So here's the portal vein right here. Here's the hepatic artery. And just like I said before, remember those blood vessels stick together and the common bile duct is climbing over the top of it. This common bile duct is at least the same size as the portal vein, if not bigger. So this is definitely pathologic. This patient probably has choledocholithiasis. Just one more portal triad here for you to practice your portal triad skills. So here's portal vein right here. Hepatic artery looking at us in this little circle, and then the common bile duct climbing over the top of it. This patient's actually had their gallbladder out, and they have just a little bit of subtle dilation of their common bile duct because of reservoir effect. Just a little bit larger than typical. It's still within the range of normal of less than 6 millimeters. All right, another gallbladder. Positive or negative? This is them trying to find the portal triad, but we found what we needed to see, which is that there are a bunch of gallstones up in the fundus of this gallbladder. So make sure you look all the way through the entire gallbladder before we call it negative. Here they're trying to find that portal triad lighting up, but it's just not going to show up for them. Sometimes it's pretty challenging to find that little teeny tiny hepatic artery, which is probably right there, and differentiate it in the same view as the common bile duct. Here's another gallbladder. Positive or negative? So things to note, no thick walls, no pericholecystic fluid, but see this dense shadow back here? It'll be a little bit easier to see in the next view, which is of the same patient. Here's the fundus of the gallbladder and the body, and then down in the neck is where all the gallstones are. This dense hyperechoic line with acoustic shadowing is a layer of gallstones. This brings up the importance of making sure you have a little bit of distance behind the gallbladder or whatever structure you're ultrasounding to make sure you have findings. You can see the findings in the distal or deep portion of your ultrasound. If you had the bottom of the screen here, you might miss the fact that there's gallstones that are shadowing here. This is a patient that I saw. He was a retired chief in the community that I was working in. And he came in with some very concerned paramedics because he was having these episodes of severe epigastric pain without any clear etiology. He had had a stress test that was negative, and he'd had a CT scan a couple of months prior with one of his first episodes, and they never really found the cause of his pain. This ultrasound shows the gallbladder. The previous point-of-care ultrasound done by a different provider was complete, but it didn't show this finding. I think when the patient came in and saw me, his condition had progressed enough that we could finally catch it on ultrasound. So if you are looking at this carefully, you may notice that there's no stones in this gallbladder, but there is this subtle area of a kind of a black collection of fluid right around the wall of the gallbladder. Maybe the gallbladder is just a little bit irregular or shaggy looking. This is not a complete view of the gallbladder, but when we did some more clips, we didn't find any stones, and this patient actually has acalculous cholecystitis. So the textbook says that this happens in critically ill patients, but there is a small number of people who just come in from the community and are not critically ill who may develop this condition for other reasons. This person probably had a dysfunctional gallbladder that wasn't emptying correctly and would have been diagnosed had he had a HIDA scan prior to this episode. But by the time he came to see me, he had probably an infection that was starting to cause this inflammation around his gallbladder. All right, let's move on to kidneys. So I remember trying to diagnose hydronephrosis in normal kidneys. It was really challenging if you haven't seen any examples of hydronephrosis. So we'll take a look at mild to severe hydronephrosis and a few examples of normal. So the kidney itself has a hypoechoic kind of area on the outside with this hyperechoic collecting system. When the calyces are collapsed, you should really see no fluid collections within the collecting system at all. Once they have a little bit of swelling, you'll see these little puddles. If it's slightly abnormal, then that means it's mild hydronephrosis. Once they have moderate hydronephrosis, really the entire collecting system is outlined. So you see all these calyces, you can see all the edges down into the pelvis with moderate hydronephrosis. Most of the patients that we see have moderate hydronephrosis. You have to have some sustained swelling in order to have severe hydronephrosis. So this is severe. Two things to notice. One is all the fat within the collecting system is pretty much gone. It's all been stretched out. And then the next thing to notice is that the cortex, this outer area of the kidney, is actually starting to get thinned. So they're actually destroying the baseline structure of the kidney with the swelling within the calyces. So this is an example of normal. Here is the collecting system is nice without any fluid collections in it. There's a couple linear anechoic areas, which is typical blood vessels. So this is normal. This is mild hydronephrosis. Before I start the clip, just notice there's a couple puddles in the collecting system itself, but this patient also has some prominent pyramids. So the pyramids are out here, and it is where the loops of Henle are, and so it's not atypical for them to look really black or really hypoechoic. So out here, pyramids, but on the inside in this fatty tissue area is going to be the collecting system with mild hydronephrosis. So that's mild. This is moderate. I always think it looks like broccoli. So here's the stalk, here's the little florets of the broccoli. You can see the entire collecting system is outlined. This patient also has a couple of prominent pyramids that you can see out here in the medulla. But here we're seeing most of this collecting system is dilated and is easy to see. So clearly abnormal, and this would be moderate. Here's an example of moderate starting to try to be severe. So this collecting system is all dilated, and you're starting to see right here and right over here that the medulla is starting to thin out. Here's an example of fully severe. So this patient has just stretched out their entire collecting system, and it actually just looks like bubbles. The difference between this and cysts is that this is a collecting system, so each of these bubbles connects with the other ones. So this bubble right here, we'll start back at the beginning here. This bubble goes into this bubble, goes into that one, goes into that one. They all connect together, and that's how you can differentiate this between this from cysts. All right, here's a patient who has collecting system right here, a little bit of fluid in there. What do you think? Positive or negative? This one's positive, and I would say it's probably moderate hydronephrosis, but if you said mild, we wouldn't fault you, it would still work. This one's really challenging because there's a rib shadow right over the top of it. I could say this is an example of how important it is to get the rib off of the kidney, and ways to do that is to have the patient take a deep breath and hold it, or to move that probe even more posterior, sometimes all the way around to their back, in order to get this rib off. Honestly, this clip is in here because when this patient was ultrasounded, the provider noticed that there's some areas within the collecting system that look really dark, but it was consistent bilaterally, and they put color on it and they found out that they're actually vessels. Here's another kidney, much better image than the last one. Positive or negative? These are big fluid collections. Sometimes people will say this looks like a paw print, so big pads of a paw and then a footprint right here. So this is a dilated pelvis and also a collecting system. This is moderate hydronephrosis. Positive or negative? Hope you said positive. This looks like a stalk of broccoli again. Florets over here, big stalk right here, and then the ureter going this way. This is hydronephrosis. In case you don't recognize it, this is the same kidney we looked at the beginning. This is that moderate hydronephrosis kidney that's starting to try to become a severe hydronephrosis kidney. So it almost looks like the calyces are trying to eat the little pyramids. So they're sort of blending into the pyramids and stretching out to the edges of the kidney. This one's a little tricky, be careful. So here's the collecting system right here. And this kidney has really prominent pyramids. So if you thought that there was hydronephrosis here, I tried to trick you two ways. One, there's lots of pyramids here. And then the other one is that there's lots of really prominent vasculature in this kidney. So if we go back to here, right here, these little fluid collections are here, but they're all really linear, which is pretty consistent with vasculature. If you were doing this ultrasound in real time, you could simply throw color on it and confirm that these are actual blood vessels and not hydronephrosis. Positive or negative? I hope you said positive. This is a big pelvis with lots of dilated collecting system, calyces. So moderate hydronephrosis. This kidney is a little hard to grade for the degree of hydronephrosis it has because they're trying to focus on this one little minor calyx over here that has a stone in it. So here's a little renal stone here. I always ask the residents when we're going through this presentation, is this the stone that's causing this patient's symptoms? And the answer is no. Stones within the kidney, unless they're in the pelvis and they're blocking something, aren't usually the ones that are causing symptoms. The one that's causing the symptom is this guy right down here who's in the UVJ. So stones take about 40 days to pass from the kidney all the way down into the bladder on average. So this stone has been traveling for quite some time and has finally gotten stuck here. Patients usually don't have symptoms until those stones get stuck, and they have a tendency to get stuck near the pelvic brim and at the UVJ. You can measure them here and give that patient an estimate of the size of that stone. So in case you didn't notice the writing up here that the provider put on the screen, this patient has a large, simple renal cyst. No fluid, there's nothing in it, big fluid collection, thin walls, so reassuring and very common. But you can't ignore the kidney. Is there any hydronephrosis in the kidney? So this is a negative kidney, except it has the incidental finding of a renal cyst. Speaking of cysts, here's a kidney with lots of different size cysts. This is a version of polycystic kidney disease, as is this. So this is a patient who had fairly significant polycystic kidney disease and disability from that. He had lots of kidney stones. And you can see if you watch these little bubbles, this is the difference between this and hydronephrosis, is that this bubble is completely separate from these. These are all individual little bubbles of fluid, little individual cysts, and they don't communicate with each other. There are also a bunch of different sizes, and you can't even get the whole kidney on the screen. So those are other things that indicate to me as a provider when I see this that a patient may have polycystic kidney disease. Here's the collecting cyst in this patient right here. It's a little bit hard to see because there's a rib that runs over it, but there's a little bit of a fluid collection here, a little bit of a fluid collection here. This patient has mild to moderate hydronephrosis, probably moderate, but they also have a big stone right here. So this was an 8mm kidney stone that was in the kidney, not causing any problems, but is there and is visible on your ultrasound. This one's sort of fun. If you want to find bladder jets, what you do is you find the widest portion of the bladder, put color on the bladder, and then just sit there and wait. If you don't see a jet coming out of each of the two ureters for 5 minutes, then that's a positive or an abnormal scan. Most of the time we see them. Most of us don't have 5 minutes of patience, but you can do it if you are chatting with the patient and you feel like looking for these jets. in very rare occasions, they do actually show up on B mode ultrasound if there's a big difference in the tonicity of the urine in the bladder and the urine that's coming into the bladder. Sometimes you'll see a little ghosty image of gray kind of shooting around, which looks very similar to this color, except it's in black and white. That's in B mode. This is a patient who showed up with gross hematuria, so lots of clots in their bladder. One of the important things that we do for these patients is make sure that we get a sense as to how well they're emptying their bladder. This bladder is pretty big. It's too big for us to see on one scan of the ultrasound. You can see it's kind of reaching past the edges of our curvilinear probe. One of the reasons for that may be that every time he tries to pee, this blood clot right here probably sticks in that urethral opening and keeps him from being able to empty out his bladder. So these are the sorts of patients who end up having to have Foley catheters and a little bit of irrigation in order to clear out those blood clots. And then we leave that catheter in sometimes in order to help them not become obstructed again. And then have them follow up with urology. All right, this is a little bit of a mishmash of everything that's left. We're going to talk about early pregnancy and then eyeballs and a couple pictures of central lines. So let's start with early pregnancy. So the first definitive sign of intrauterine pregnancy on ultrasound is going to be a yolk sac. So in this patient, this is a transabdominal ultrasound of the uterus. What we see here is a little fluid collection within the uterus showing up right there, a little bit of decidual reactivity around it, so it's a little bit bright around it, but we don't really see any clear yolk sac, which should look like a little Cheerio in there. That can often be because this is a low frequency probe, and so we can't see details very well. Here's another patient who's coming in, also doesn't have a definitive intrauterine pregnancy. They have a different finding in the uterus. This is a transvaginal ultrasound because by dates, this person should have had a uterus that was small enough to fit onto an endocavitary ultrasound probe view, but we couldn't because they have an abnormal finding, which looks like a snowstorm, or grapes in a snowstorm. So this is a molar pregnancy. Here's another picture of an ultrasound. It's once again transabdominal, pregnant uterus. This is bladder here. This is the fundus of the uterus. Sorry. This is the fundus of the uterus right here. And then right here is the vagina. Okay. This image is helpful for one of two reasons. One is if we look at it really carefully at this endometrial cavity and you squint just right, sometimes I can make believe that there's a little circle here. It's not showing up very well on this recording. But the other useful part of this ultrasound is it shows us exactly where that endocavitary probe is going to go. So the endocavitary probe is sort of like an abdominal ultrasound or a phased array ultrasound on a stick. So the ultrasound itself is a long probe and goes into the vagina and actually seats up right here. So the anterior wall of the vagina stretches a little bit and the ultrasound probe ends up sitting right around here. Okay. It's helpful if the patient's bladder is empty because then this uterus flops forward and it's easier to see through that intercavitary probe. So the next picture that we're going to see is the intercavitary probe. Here's the fundus, and what they're doing is they're lifting their hand to tilt the ultrasound probe down because since it's a long probe, the probe itself goes in the opposite direction as your hand does. And they're lifting their hand up to see down to the cervix and then tilting it back to see the fundus. So just for orientation, let's go ahead and take a quick look here. So this is up towards the patient's head and this is down towards the patient's feet. Okay, this is probably down towards the patient's feet down here. This is the cervix. This is bladder up here. And then back here is a little bit of physiologic fluid. It's not unusual to see a little bit of fluid behind the uterus, especially with these high frequency probes that are really easy to see everything. Here's the endometrial stripe, and here's that top of the fundus. Behind this is going to be rectum and intestines. And once again, anterior up here is the bladder wall. Here's a pregnant uterus with 2 gestational sacs and 2 little fetal poles. So we don't scan quite through this one, but we can see this fetal pole over here. No significant free fluid back here. Here's the fundus, and then the cervix is kind of lost in the artifact from the edge of the vaginal wall. This is a transverse view of a uterus. So here's the endometrial stripe right here. Adnexa here, this is the left adnexa, this is the right adnexa. And as we're scanning through, we finally see what I've been talking about, which is a yolk sac. Unfortunately, this yolk sac is not where it belongs. So this little yolk sac right here, little perfect Cheerio right here, is in a fluid collection, a gestational sac, which is not within the uterus itself. It's next to the uterus, it's adjacent, but the place where it belongs in the uterus is right here. This is the endometrial stripe in the middle of that uterus. So this is an ectopic pregnancy that's right at the edge of where that fallopian tube enters the uterus. Other findings on this is a lot of vasculature, which is common in pregnancy. And if we keep on scanning through, we'll often see this, which is an ovary. It's got a couple follicles and a dominant follicle on it. Big follicle, ovary. There's that ectopic pregnancy, and here's the uterus itself. Here's another sagittal view of a uterus. This is a patient who has had a miscarriage, and they still have some blood, possibly products of conception within the uterus itself. Now remember, a ectopic pregnancy with vaginal bleeding and a incomplete miscarriage both look about the same on ultrasound, so that's something clinically to be aware of. And you want to make sure you're taking that into context in your clinical decision making. This patient also has a little bit of free fluid posterior to the uterus and a simple ovarian cyst. So you see there's one thin-walled fluid collection here in this ovary. This is the uterus up here. It's kind of challenging to see because of near-field artifact, but what we're really looking at here is this big, large adnexal finding, which is a hemorrhagic ovarian cyst. So these are difficult to differentiate between infections or masses. But in retrospect, given this patient's clinical history, this was a large hemorrhagic cyst. It has this very typical kind of homogeneous hypoechoic grainy pattern. This is a very large cyst, almost too big to tors, but still probably needs radiology to confirm that there's good flow to this ovary. It's about 8 centimeters. Here's another uterus. This is transabdominal, and this is another ovarian cyst. So simple ovarian cysts are going to be thin-walled, have no echoes within them, and have no color flow, and have posterior acoustic enhancement, which is when it gets brighter behind the cyst than it is in the surrounding area. This patient has 3 of the 4, but they have a bunch of little fine lines in here which indicate that this is a septated cyst. These can end up being malignant, and so this patient needs further workup and careful follow-up to make sure that she gets appropriate care. The uterus itself is empty. No pregnancy here. The concern for this patient was not pregnancy, it was really more discomfort in the right adnexa from this cyst. All right, moving on to ocular ultrasound. So the eyeball, here's the anterior chamber of the eye, here's the posterior chamber, and here's what we're looking for in these eye ultrasounds, is we're looking for the retina. The retina is very bright and shows up really easily in patients who have retinal detachments. Here's an example of an eye ultrasound. Here's the anterior chamber. Right up here is the iris. Here's the posterior chamber. On this patient, there's a big ribbon of bright white hyperechoic tissue here, which is a detached retina. This patient has a fairly large segment of their retina has been detached, and so it actually goes all the way from the edge where that retina starts, all the way down to the optic nerve, which is where the retina vessels, the retinal tissue connects to the optic nerve. This is a patient who has visual disturbance and comes in for flashes and floaters, but what they have is very difficult to see. What we had to do is we had to turn up the gain a lot. See how bright this posterior tissue is behind the eye? This is a vitreal detachment. So the vitreous, when you're young, is this big glob of gel that the eye forms around. And as you get older, that glob of gel dehydrates and slowly turns basically into a big raisin. When that raisin dries up, it can sometimes have little connections to the retina and can pull on it, which is why this patient was probably having flashes, is because this vitreous was pulling on the edges of the retina. That can sometimes cause tears, and so these patients should still have follow-up with ophthalmology, although the vitreous detachment is not actually the problem that needs any treatment. They actually need further evaluation for possible very small areas of retina tear or retina that is being pulled on with traction. This is a patient who has a significant amount of swelling of their macula. This isn't typical for most patients who have macular edema, but this particular patient had a complex history and so had a very swollen macula. If you find the area of the eye where you can see the posterior lens and the optic nerve at the same time, here's the optic nerve right here, then the macula is going to be right next to that area. So usually the macula is not sonographically distinct from the rest of the eye, but in this particular patient, because of her pathology, it is. And so you can see where that area is right in between that lens and the optic nerve sheath. Here's another patient with a very large retinal detachment. This patient actually has a detachment of both the right and the left retina, which you can see anchors down to the optic nerve sheath. If you see a tiny tear on the side of the eye that doesn't go all the way down to the optic nerve sheath, that doesn't necessarily mean it's not retina, but it does mean it's small and early, and that patient should have prompt ophthalmology follow-up within the next 24 hours if possible. All right, couple pictures of central lines. Here is a very hypotensive patient. So here's the IJ right here, the internal jugular vein. Here's the carotid artery. And there you can see this indenting in as they put the needle through. They hit the back wall. And they actually have to go all the way through both the anterior and the posterior wall of this internal jugular vein in order to get the needle through any of the walls. So they actually do what's called back walling it, where they actually poke through the back wall. And in this couple frames right here, you can see that back wall pull up as they withdraw the needle and then pop off right there. Came from up here down to here, pop off of the needle. So now this needle is within this blood vessel. Now they can go ahead and put in a wire and put that catheter into the blood vessel. This patient is not as hypotensive, but you want to make sure that you're not pointing the needle when you're doing this axis right directly towards the carotid. So in this patient, we either need to change the patient's head position so that this IJ moves away from this carotid, or we need to change our approach so that we're not going directly towards the carotid and instead maybe doing an in-axis approach so that we can then see the needle and it's not going to go, if it has difficulty getting in through the blood vessel, it's not going to back wall directly into that carotid vessel. Before you place the catheter, you want to make sure that you confirm the wire. Before you dilate this vessel, it's preferable to make sure that we're in the right spot. So this is IJ right here, this is carotid down here, and this is us confirming that wire in short axis. You can see that nice reverberation artifact off the edge of the wire. You want to also confirm it in long axis. So this is carotid back here, this is IJ right here. You can see this wire being confirmed in long axis. You can even follow it down a little bit to make sure that it's staying within the IJ and didn't slip into the carotid on the edge. And that is it for all the presentations. Thank you for your attention, and I hope the rest of your ultrasound rotation grows really well.